Hello, my name is Matthew Kroll. I'm a intern at Rush University Medical Center. My case for you involves a 71-year-old woman with chronic hyponatremia and stage 4 lung adenocarcinoma who presented with 2 weeks of generalized weakness, leg pain, leg spasms, and a new difficulty in walking. Her physical exam on admission was striking for a 3 out of 5 weakness throughout her bilateral lower extremities and significantly increased tone and hyperreflexia diffusely in her upper and lower extremities. She had a persistent plantar flexion, which was quite painful for her. Her admission labs were significant for her hyponatremia as well as an elevated creatinine kinase. On day one, we began to correct her hyponatremia with a fluid restriction and salt tabs, but this did not improve her symptomatology once she returned to baseline. An MRI of her C spine didn't show any sort of causative cord, though it did show some metastases of the primary disease. An EMG on day 3 did show abnormal frequent simultaneous firing of the voluntary muscle units in the tibialis anterior and the gastrocnemius muscles while they're at rest. These are two muscles that are involved in plantar flexion of the foot. And in this context, it was concerning for stiff person syndrome. We treated her with diazepam and high dose steroids, and over the course of 2 weeks, her spasticity improved and we were able to discharge her to an LTAC. Further workup for stiff person syndrome, including an antibody panel, was negative, however. Now, stiff person syndrome is a rare disorder that's characterized by painful remitting and relapsing spasticity of the axial muscles, but it can also include the extremities, as it did in my patient. It was originally called stiff man syndrome. However, in the 90s, they changed it to stiff person syndrome because around 70% of all cases of SPS are in women. It's caused by pathologic antibodies that will target the GABAergic pathways and cause a spastic paralysis in patients. Diagnosis remains a clinical one, however, there are some unifying features, including stiffness in axial muscles, which will impair ambulation, episodic spasms, which can be precipitated by a sudden movement or even an intense emotion, and clinical response to diazepam. Now, there cannot be any other explanatory neurological diseases, or else it won't be considered a diagnosis of stiff person syndrome. Complications can include fractures and dislocation from very violent spasms. If the cricoid cartilage is involved in either stiffness or spasticity, the patient can have hypoxic respiratory failure. If the esophagus is involved, similar to the cricoid cartilage, there can be an obstruction and you can get uh, dysmotility and GI obstruction. Now, it's associated with type 1 diabetes most commonly. 30% of all cases of SPS are associated with, are in patients with type 1 diabetes. It is not as commonly a paraneoplastic syndrome. Only about 5% of all these cases are paraneoplastic. Workup will include an EMG, which will show the continuous firing of motor units while at relaxation. And you will also get a serology, not because they're very sensitive, about 30% of cases are seronegative, but because it's good for prognosis. The most common antibody is anti-GAD, which is the rate-limiting enzyme in GABA production. Therapies usually involve high doses of GABA enhancing and GABA agonist drugs for symptomatic relief, including diazepam, but doses are very high and quite sedating. Some courses are suggested include 60 milligrams QID. The only thing that has been proven to reduce spasticity and improve ability to move is IVIG, but it was a small 16-person placebo-controlled trial. Now, this case was very interesting to me because it did help me recognize an uncommon cause of weakness in my patient. And it is a treatable cause of weakness. But the average time from diagnosis of this disease is 6 years, so it's important to remember these zebras, especially when they're treatable, to prevent unnecessary morbidity. Thank you for listening.